So, good morning, everyone. For the next topic, we welcome to the section of the polytrauma and multiple trauma. We have many topics in this section, so we have to go forward for the first one. Dr. Yanin, please.
So the first topic is gonna be a DCO in polytrauma patient up to date by Dr. Pasawat.
Okay, so good morning, Chairman, the moderators, and our audience. So my name is Pasawat from Lampang Hospital. Today we will explore about the role of the damage control orthopedics and managing in polytrauma case, and we mainly talk about the concept and philosophers. So the polytrauma patient is usually involved in multiple body system with a high risk of the death. And about the definition, in 1975, the body suggests that more than two injury in more than two body regions. But in 1984, Schoen suggested about two or more injuries, which at least one of life-threatening condition. In 2000, trends with the in AO principle suggests that a syndrome of multiple injury that including ISS score more than 17. So what is the ISS score? It comes from the AAS score from abbreviated injury scale. It depends in 9 regions and have a 1 to 6 score with the summary of the 3 highest AS with a square. So the max is 75 points, and if some parties have AAS more than 6 or 6, is mean IS is 25 is max. So in the 2012 from Australia, if we have a more recent definition suggests that AAS score more than 2, at least 2 body regions is polytrauma. But in the consensus in 2014, the Journal of Trauma Acute Care Surgery have developed the Berlin definition. So it's based on a consensus meeting and database analysis. It concluding the ISS more than or equal 16, and the AS score more than 3 and at least 2 body region, plus with 1 or more pathologic condition. So the principle of the polytrauma management is assessment and resuscitation. So we should provide the ATUS protocol in the golden hour. And another priority is the safe life, safe limb, and the safe function of the patient. In 1977, we have a debate about if the patient is too sick to operate on. So we go back for the pathophysiology of the polytrauma with 2 basic elements. One is shock. It leads to the metabolic acidosis, hypothermia, coagulopathy, and overall it's a renal triad. And the second one is the inflammation. So it releases some of the mediators and develop the cells. The lethal triad is about coagulopathy, hypothermia, and the metabolic acidosis. So it's a vicious cycle. That means once you get in, it's really hard to get out. And about the systemic traumatic reaction. So in the summary, if the long bone was unstabilized, it can lead for the ARDS from the remote organ failure. So it relates with the systemic inflammation. Also, every injury can lead to a remote, especially in the lung. Okay, so what is about the concept of the polytrauma patient treatment? So in 1989, Dr. Lawrence Bone suggests that it's a high complication rate if the delayed stabilization of fracture in the polytrauma patient. So they developed the early total care, or we know as ETC. This concept suggests the fixation of all fracture within 24 hours for the early ambulation. It's a good result. But Christopher Pep and Harold Schön in 1999 explored that the ETC is not suitable in the all patient. Why? So we call the second hit phenomenon. The second hit phenomenon caused by the further damage that can make more the mediators and dissolve in cells. Actually, the fixation of the long bone that can cause the remote organ injury by the mediator. So it can cause of the ARDS too. Then the second concept was introduced by damage control. It's firstly the word is used in the novel term. It's about keep the chip in the throat and functional by shut some compartment have injury. So this concept was first described by Scalia in 2000. So a wide measure operation during a peak of the cells and do the stage treatment of the fracture. So the DCO is going to limit the second hit, do the minimal temporary stabilization of the fracture in severe trauma patient can lower the complication. Then the ELA of the calcification count. So we define the polytrauma patients into 4 categories: stable, borderline, unstable, and in extremis. So the stable that you have seen before is 4 categories. But in 2002, we still concerned about the timing of the fracture treatment. The skyline was developed. The stable patient will go for the ETC. But the unstable and in extremis go for the DCO. But in the borderline, or we call the at-risk patient, maybe need some the surgeon opinion. So what we did in the long time ago, if the leg is more than 2, base excess below -2, and pH lower than 7.3, so we call DCO. Is the simple decision concept. But until 2013, Dr. Heather Valia from Cleveland, USA, published this landmark paper. It's about early appropriate care, or EEAC. So the concept is that do early total care when the patient has been resuscitated for the new parameter. The lactate is below than 4, pH more than 7.25, and base excess more than -5.5. So do the ECO, then resuscitated patient until the parameter reach, then go on ETC. Many papers support its concept. It can decrease complication. Then in 2015, the Safe Definite Orthopedic Surgery, or SDS, developed. This concept was introduced by Hans-Christoph Pep. It's to refine the DCO strategy and avoid the overuse of the external fixator for convenience. Instead of the single indicators, they use a multiple indicator for the comprehensive treatment, such as coagulability, balance of the infusion or the fluid, presence of the boosting agent, and respiratory function. So it's developed that in day 1, if patient is stable enough, go to the early total care. But in the borderline and unstable, they suggest for the DCO at first. Then they re-evaluated the patient in 24 hours. So it depends on the stable and borderline. And reassess every day. When patient stable, go for the total care. But again, in the next year, 2016, the new concept was introduced by the Janudis. It's about prompt individualized self-management, or we call PRISM. This concept is doing no further harm. The patient depends on the patient and the resource of the hospital. It's about prompt is consider about the resource and do not set the time limitation with the delay of the treatment. For individualized, consider about the factor of the patient. Therefore, about the safe, proper treatment with doing no further harm. And last one is the management. So we resuscitation the patient and give the proper choice of treatment. So in summary of the philosopher by the time, first we developed the ETC in 1980s, then the DCO in 2000, and ESC or early appropriate care in 2013, and about the safe definitive surgery in 2015, and the last one is the PRISM in 2016. So I will summarize all of the philosophy. First, we should understanding the physiological response of the major trauma patient about the first hit and the second hit. Then should be concerned about the second hit too much, which may be originate in the timing, and the fracture fixation then can cause the multi-organ failure soon. And if the patient was stable, you can go to the ETC safely. But about the damage control, should we do the patient in the borderline patient, unstable patient, and the in extremis patient? Now there is no time limit for the definite treatment. Do it when patient stable enough. And the last one is individualized management should be concerned by the patient and the local resource of your hospital. Thank you.
So thank you, Dr. Pasawat, for the interesting topic and useful topic for the update of the DCO principle. So for the next section, we have to go forward to the next interesting topic for evaluate the patient to do the safe surgery for the polytrauma patient. So the next topic is biomechanical marker in the polytrauma from Dr. J from India. Dr. J, please.
So good morning to all of you. I thank Thai Orthopedic Society for giving me the invitation. Can that come on here? So my place is from Coimbatore, that is in India. It is down south. So can I run this? Okay, so it is in the down south, and then when it is in this place, we have a 600-bedded hospital purely for the trauma. And ours is a major hospital which receives a lot of patients. Inpatient registration, if you see, there is nearly 25,000, of which we have received 123 polytrauma in last 1 year, and ours is a big trauma group. You all know that there is a Ganga Hospital score which we have published on the open injury based on the large experience that we have. Polytrauma by far is something that you need to look at it as previous speaker told, like either you do a global reconstruction or wait for to do in stages. But what decides you to do this is like you need to take care of the few of the biochemical markers and then stage them accordingly. Let us look at this patient for whom is a 46-year-old. If you see all this ATLS protocol that you do, and then on that you see a heart rate is 90 per minute, and then BP is not recordable on arrival, and saturation is very low. And he has got a head injury, and then injuries in the limb as well as the chest, and then the abdominal injury. When you take all this into account and all the parameters that you took, see like these are the various injuries he has got. He has got a depressed frontal bone fracture, fracture ribs, pulmonary contusion, myocardial contusion, open book pelvic fracture, and other limb injuries that he has got. And then if you look at it into the calculator and put all these, you get an ISS of 45. Anything that is ISS of 45, you know that the mortality would be very low. And then also if you look at what is the probability of survival, there are various scores that are available, you can put it, and it is only 44% that they would be surviving. So these, if you look at it, on arrival, all the parameters on the left side is almost all right. What is important is to note is that the serum lactate that you check is 8.9 and troponin was positive. So in that bargain, so you need to think that he's not going to be all right because you need to resuscitate them very well and then do the damage control orthopedics and then continue resuscitation and ICU management. If you look, the lactate was what was on arrival 8.9, by 24 hours it becomes 2.9. If you all know that the lactate level, if it remains high after 24 hours, it would be very difficult to survive. So immediately you must get them reduced and then they will be able to survive. So this is the various thing. You can see that it's almost becoming like a white lung. And then in this stage, then you need to do only the damage control surgery that you need to look at. And then later on you can do, and then do the ICU management, and then go on to do the definitive management. But that is the way you look at it in any of the polytrauma scenario. But polytrauma, by far, you must look at it as a disease of hemorrhage. If you understand this concept, it is extremely good. It is a disease of hemorrhage. That means you need to look at what is important. So you know that hemorrhage, it is in shock. That means you need to get them back to stable position. That means you need to get a normotension, that is blood pressure become normal. And then the heart rate should become normal, and the urine output should be normal, urine output should be maintained. Suppose if these are the stable parameters, what is important is in the tissues. The tissue needs to be oxygenated well. That means the perfusion must be good. The perfusion characteristics of the tissue, that the metabolic characteristics of tissue is noted by the lactate levels. Suppose if there is no metabolism, then the lactate level would be high because the anaerobic metabolism sets in and the lactate levels would be high. So that's what you need to look at. And the lactate determines the tissue oxygenation levels. Suppose if the tissue oxygenation is also good, that means the lactate levels are normalized, then that means that the patient is resuscitated well. In that instance, you can go ahead to operate on them. On the contrary, if the lactate levels are high, that means the tissue oxygenation is inadequate. That means then you need to think that they are in the occult hypoperfusion stage. And when you operate in the hypoperfusion stage, when the tissue oxygenation is not adequate, the patient is going to have a lot of problems. That's what it means. Basically, a polytrauma scenario, this is what you need to look at. And then we also did a study where we found out that if the lactate levels remain very high after 24 hours, the mortality rate is very high. So that is what you need to aim at. And moment the patient comes in, make sure that you collect lactate levels and then do that, and then continuously do it every 2 hours or 3 hours, depending upon your hospital protocol. And we do it in 4 hours protocol, and then we find out that if it is reducing, that means you are giving an adequate replacement of fluids to make it all right, and then you can get them to good resuscitated levels. And also you need to look at the surgical strategy. That's what you do. Suppose if it is stable and resuscitated, that means the vital parameters are good and the tissue oxygenation is good, then the surgery is safe. Suppose if there is a hypotension, that is occult hypotension that you have, that means it further needs resuscitation, but if everything is stabilized, then you can go ahead to do it. Whereas if it is not stabilized, then you need to do a damage control surgery. This is the basic concept by which you operate in the polytrauma. That is one part of it is the polytrauma that you need is a disease of hemorrhage. The other is that you need to look at is the quantum of damage that it has got, because the various tissues get injured. The soft tissues are getting injured, and then the quantum of damage to the soft tissue is determined by all this inflammation that takes place. Any tissue damage is going to bring an inflammation. So inflammation could be a pro-inflammatory or an anti-inflammatory. So this is the way you look at it. And based on the quantum of damage, suppose if your surgical load is very high, then it is going to give you the second hit phenomenon. That is what you are going to address in a polytrauma. So the second hit, you must try to reduce it. So between these two pro-inflammatory and the anti-inflammatory markers, IL-6 is supposed to be the one that you need to estimate. So though these statements are good, but what is important is that the parameters that you look at is interleukin-6 or the procalcitonin or the CRP. But CRP remains high throughout the phase because of the polytrauma, so it is not a good indicator. On the contrary, procalcitonin acts like an acute inflammatory marker, so it is very good in infection. Whereas in all these inflammatory markers that it happens in a polytrauma, it is the IL-6 that we need to investigate. And then like one of the article by Gyanodis et al. Has found out that the 200 picogram per ml is the best level. Suppose if it is very high, you need to stage it. Suppose if it is less than 200 picograms, then it is safe to go ahead and do the surgeries. So interleukin-6 is one that is going to give you an outcome where you can predict the outcome. So that is, if it has to remain within the 200 picogram levels, then it gives you this thing. So based on these two markers, then you can decide the timing of the surgery in a polytrauma. So let us look at this 26-year-old. The previous case, I told it was the interlactate levels were very high. And then here we are looking at a patient where the interleukin, that is the lactate levels are nearly normal, that is at 2.43, whereas the interleukin levels are very high here, it is 616. So in this patient, you can see that it is purely like what is important in this patient is you can see the fractures of the ribs, and then also he has got a femur. So there is a direct correlation between a femur fracture and a chest injury. There are studies where it is found that a chest injury with pulmonary contusion, if there is a femur fracture, the mortality is also high. So if you look at it here, if you put an ISS score, it is somewhere around 29. And then when you take the X-rays, and then in the clinical parameter, because of the flail chest, he was not responding very well for ventilation. So in those instances, better to wait and see if it is not responding, if the ventilation parameters are not becoming adequately good, then we have to go ahead and do a rib fixation. So you see that we have done the rib fixation there on the second day. And then after rib fixation, it is easier to do a prone ventilation. Many times, the lungs that are recruited for your ventilatory purposes in supine position, you may not have a good lung parenchyma to have a good oxygenation. So that's why when you put them in prone, it will be easier for you. So you can see the sequence. They are undergoing a prone ventilation, and then suddenly on fine day, it also has got a problem of ventilation also. And then the same stage, you can also see that there are procalcitonin levels also increases. Whereas on the contrary, the interleukin-6 gradually comes down, and that means the tissue, whatever the impact of the tissues are coming low. And then gradually you can also see that the urinary output remains good enough. So in those instances, if you maintain with the ventilation, then all the parameters become better and better. But even then, there is some instances during the ICU phase, patient's blood pressure, everything can crash. But if you can maintain them well and then follow these two parameters extremely very well and then go on to have a good intensive care, then you can get the patient better. So after that, then you can go on to do the definitive fixation. These are 2 months, the patient is doing very well. So what is important to note is that for any surgery in a polytrauma, you have these two parameters into account. Think polytrauma as a disease of hemorrhage, and polytrauma as also the impact of various tissues that are getting damaged. And then it gives you a hemodynamic, if these parameters are good, like hemodynamic stability, and then oxygenation, lactate levels are normalized, coagulopathy, normothermia, and urine production, everything is normal, then you can think of doing a staged surgeries without any problem. So these are the two parameters that you always take into account in polytrauma. And if you are taking care of these two, then all your surgical results will be extremely good in these situations. Thank you all.
Thank you very much, Dr. J, for your excellent talk and your research from Kankar Hospitals. The next topic is going to be external fixator, the holy grail for DCO by Dr. Sutiwat Leungsot from Ubon Ratchathani Hospital. Please, Dr. Sutiwat.
Good morning, Chairman and Co-Chairman and the audience. It's my honor to share my experience about the external fixator, and thank you for the very good talk, the previous topic, because everything know how to decide to do the damage control orthopedics for the patient. Let's start with the case. This is a male patient, 21 years old. He got the multiple injury, and then he got the head injuries too, and the score is not good. And then another one is pelvic fracture, femoral neck fracture, and distal femur. But we sure we are going to do the X-fix to do the damage control for this patient. And then we do the damage control. We put the X-fix in the pelvis and then in the distal femur. And then 2 weeks, the patient is stable and recovery. This is X-fix do their job for the damage control. But when you see the CT scan after the 2 weeks, this one, you will see it is shortening. Another one is the interfluoroscopic. You see the shunt pin is broken. Usually, the X-fix is a holy grail for the damage control orthopedics. But please don't make it a hell for the definitive. This, in my experience, the patient with the neuro condition, usually the patient will move a lot because they didn't fully conscious. And usually when you do the spanning, the safe zone is in the lateral of the femur and in the medial of the tibia. You will see this is have a lot of the lever arm and the shunt pin. When the patient move too much, it may be cause the shunt pin to broken like this. And we can put it in the anterior of the thigh, so you can see it's the less lever arm. But is it safe to put it in anterior? Yes, we have the safe zone for the external fixator in the anterior of the femur. The damage, the structure at risk in the proximal is the femoral nerve, and in distal is the patellar pouch, because if you put to distal, it may be in the joint and then can cause the septic arthritis. And when the study showed the last branch of the femoral nerve is about 5.8 centimeter from the lesser trochanter, and in the distal part, it should be proximal for 7.4 centimeter from the suprapatellar area, and this is 20 centimeter is a safe zone. And when we put it in the anterior fashion, if you want to definite in the plate fashion, is not obstructed definitive treatment. So if the alignment is good, you can remain X-fix and then only the nipple. This shows this not obstruct when we put the plate, when the shunt pin is on the anterior. And goal of our external fixation is a rapid application and stabilize the injury musculoskeletal. But one thing I want to mention is the length is very important, because when we do the damage control, we don't know when the patient recovery and when we can do the definitive. If you put the X-fix stabilize in the shortening one, when it's maybe 2 weeks or 3 weeks, it's very difficult to length. We have to do much resection and release the soft tissue to length it and got the leg length. So this is how to do the X-fix to maintain the length. First, we have to traction first to restore the length. If you put the pin first, maybe when after you finish to put the pin and try to pull the leg down, it's not go because the fascia is obstructed by the pin. So first we are traction, and then after we see is you got the adequate length, so you can put the pin to stabilize. This will cause you can got the correct length because before apply the external fixator. Another one is we know the safe zone is in the medial. Can we put it in the anterior pin of the tibia? First is described to avoid it at the tibial crest because it's very thick bone. This one should not be applied because it maybe got too much heat. And how to do it in the anterior style, not to slip because it's the medial tibia is just the slope. So you can put the dew in this direction a little bit to make a little hole for the drill bit to drill in, and then you change the direction so you can got the anterior pin. And easy step for the anterior half pin in the anterior tibia. This is from the atlas of the insertion transosseous element reference position from Professor Solomin. They divide into 8 sections. The zone 3 to 6 is available for the half pin. This I will show you. You can put it in just medial or the half pin at the zone 3, zone 4, 5, and 6. But zone 1 through and 7 and 8 is not possible to put the half pin in the anterior. And position of the leg, someone is just put just a slightly flex knee and put the X fix. From my opinion, the straight leg is very easier, that you can put the traction and then you can care and the patient comfortable. Because when you put it in the slightly flex knee, it's just like the conical. When they move the leg, it have more lever arm. But if in the straight leg, it's more easier and more patient comfortable. This one. And the supraspinatus X fix, because in the pelvic fracture, they have some emergency condition that you have to put it very fast. But this is, we need intraoperative fluoroscopic to assess the corridor. But now we can put it in the, without intraoperative imaging. But you have to put the more widened incision, and then you use your finger to palpate the inner side, and then make a only drill at the one cortical, and then you insert the shunt pin in through the bone tunnel. Yes, and we have the paper. This from Dr. Narupon is to compare that we put the X fix in supraspinatus fashion, compare with fluoroscopic or non-fluoroscopic. They say it's use less time to put the pin, but we have to a bigger wound, but no different in the complication. And another one is the X fix we know is for damage control, but we can use it for definitive treatment too. This patient is open fracture tibia and a little bit of bone loss, but at the first time, the fibula that you see in the first radiographic is outside and the soft tissue is not good. And if we have the good plan, so I decide to resect some bone and shortening and then close the skin. And another one is lengthening. So the X-fix can be the damage controls and definitely treatment too. So please make it the external fixation to be a holy grail for the damage control and for the definitive treatment. If we got the length and then we put the implant in, it's very easy. But if it's shortening, it will be a hell for you to put the implant. So my take-home message is planning at the first time for the definitive treatment is very important when you want to put the X-fix. Know the safe zone and the correct technique so you can get the good length alignment and the position of the X-fix. And the length is the very important. Thank you.
So many thanks to Dr. Sutiwat. And the next topic is about bilateral femoral fractures, how to make a deal from Dr. Songpon Pim Prasan from Uttaradit Hospital.
Good morning, chairman, co-chairman, all faculty and all participants and audience. Today, I will talk about the bilateral femoral fracture and how to make a deal. I'm Songpon Pimpasan from Uttaradit Hospital. Today we'll talk about the outline of these topics. It's a morbidity and mortality of the bilateral femoral fractures. and the fat embolism, early intermediary nailing in the bilateral femoral shaft fracture, and compare with a single and two-stage fixation. And an example of case, the patient with the bilateral femoral fracture have a higher overall injury severity and have higher incidence of morbidity when compared with the unilateral femoral shaft fractures. And the bilateral femoral fractures are more more often associated with abdominal injury and hemorrhagic shocks. As we know, the IS score is the score to tell the prognosis of the disease and can be calculated from the clinical patients. But in the patient, especially in the isolated musculoskeletal injuries, have the underestimate of the IS score, so maybe at least for the surgery. Okay, when you have a patient with a multiple injury and have bilateral femoral fractures, when you indulge the patient is stable or not, try to do the DCO because of they have a publish of Journal of Trauma in 2014. They use the data analysis and make the least adapt approach for this and prove that is the DCO is safe for the patient in these conditions. So the next is fat embolism syndrome in the bilateral femoral fractures. In the bilateral femoral fractures, the fat embolism is the main relevant complications. Despite you have the good DCO strategy and the good reaming techniques, when compared with the unilateral femur, it's still more high incident for the complications. And for the compare with the each bilateral femur fractures, the time, mode of fixation, press or nail, or the history of other injury is not related between the group. And for the fixation in the emergency conditions, when we do the research about the mortality and ARDS between DCO and ETC in the bilateral femoral fracture, the rate is not quite different. But if you don't have the perioperative team or the ICU or the good anesthetic team, is quite be dangerous in the ETC. Keep in mind is you need to good team before to do the ETC. Okay, and when we choose the patient who are candidate for the early fixations from the EJOS and 2023, they report about the patient who might benefit from the early definitive IM nails. The patient who have the only ortho conditions, not ICU condition, multiple conditions such as the head injury, chest injury, or the patient with a history of the OR can be do the early nailing. And the patient with low BMI, less IS score, and less blood cell transfusion is the good candidate. Beware of the other conditions such as the abdominal injury, pneumothorax, and other medical conditions. It may be risk for the early nailing. This is a conclusion of the papers. And next, other factor is the influencing the management of bilateral femoral fractures. The history of resuscitation protocol and laboratory such as the T faculty that mentioned in areas about the lactate and level of brain access. It can be tell you about the condition of the patients and history of the chest and abdominal and head injury. And medical issue is that can help you to choose you may do the early nailing or the delay nailing. Okay, this is a paragraph to show they have the laboratory to divide the patient to two groups, and in the group with less than rather than 4 millimole is and head injury and have other condition is maybe to be the DCO then and later fixations. For the patient is stable, you can proceed with the nailing. And in this paper, they tell we have to recheck after first fixation. If the patient is still stable, you do the another size. If patient not stable, wait for the next OR. Okay. Next topic is the single we at the second stage for the bilateral femoral nail. For the JOT in the 2021, they said that a single stage is better because of they have a reduced risk of ARDS. Okay, this is a sample case. I have 25 male traffic accident with aortic dissections, multiple fracture, and a kidney injury and bladder ruptures. They sent to emergency OR. Okay, that in the film at the ER show the open fracture of the left femur and left tibia. Sorry, right femur and right tibia, and also left femur and left humerus, and a fast positive. They sent to do the TIWA and the cystogram. In our team in this situation, they have no record of the wound or the X-ray because of emergency condition. We do just anterior egg fix. As the doctor Sutiwat said, is the holy gel which you do with it proper. Okay. In this case, we do the DCO. And for the patient stable, 20 days later, if you not do the good egg fix, it may be the most difficult surgery because of they have maybe the malunited of the femur or the some problem of the pin. In this case, we do the bilateral nail because of the patient is stable. On the radiolucent tables, we use a bilateral retrograde femoral nails and also use the semi-extended infrapatellar tibial nail. And after you fix the nail, you can check the length of the two legs on other sides and do the fixation and the rotation, internal rotation, and the quad leg for the external rotations. And also, if the patient is still stable, we proceed to do the nipple of the humerus shaft because I have a fan of Dr. Tirashai. Okay, this is the post-operative film for the nail, femur, and tibia, and the humerus. Okay. 3 months follow-up, the patient is full function and can walk with a single cane. This is the video. Okay, the video is not work. I will show the patient can move hip and knee properly, and also the elbow. Okay. ไม่ได้ใช่ไหมไม่เป็นไรครับ For the take-home message, bilateral femoral fracture have a higher overall injury severity. If you're not sure about the patient, do DCO is safe. And fat embolism, if you, despite you have the good strategy, they still have the high rate of complication. Please beware it. And the ETC, you have to good team, pre-operative, ANAS, and ICU. When you identify the patient who can be early IM nail can improve health, relate quality of life, and short hospital stay and the rest of the complications. And lastly, the single IM nail in first stage is reduced risk of ARDS. Thank you. ขอบคุณครับ
ส So many thank yous for Dr. Songpon for interesting topic. Okay, for the next section is the question and answer from the participant. Anyone have a question for the multiple trauma topic? Anyone, please? So I have a question from the one of our participant. Question for Dr. J. Okay. A question is, if there's only one factor in the algorithm that not meet the criteria, how to make a decision? Is it okay or not for the do the surgery?
No, there is in any polytrauma scenario. Suppose if there is a lactate normal or abnormal, if there is interleukins that are normal or abnormal. So this is the only way you can get, isn't it? There cannot be something like that. So if it is both the parameters are normal, you can go ahead and do a global recon. There is early total care you can do. Suppose if there is a discrepancy, then you are going to do a damage control orthopedics. That is the way you decide on these parameters. Am I clear?
Yeah. The most important parameter is the lactate, right?
Yes,
Okay.
that is going to tell you about the quantum of blood loss that has happened in a polytrauma patient.
Okay. And how often to monitor it? Once a day or?
No, it's a serial. Like for example, when the patient comes in and he is a hypotensive, he has to be in an ante room of the theater. So then our intensivist will continuously monitor them. So then only we can get them all right. Otherwise, suppose if you go see them today and then later evening or tomorrow, then you will lose the patient. So he has to be continuously monitored, and always our intensivist will take care of them till they get resuscitated.
Okay, thank you so much.
Thank you.
So any other question from the floor? So I have seen a lot of residents here. I would like to ask, not a question, recommendation from Dr. Susiwat, because our residents have to deal with the patient at night when they're on duties. What do you recommend construction of the spanning external fixator in your practice routinely? What the best one for you?
For my routinely use is anterior one. I like the anterior because when sometimes if we want to put the plate, it's not interfere, and then it's very strong. If you can put it in one plane, there is you no need to put the connecting rod in the just if it's you put the connecting rod in strength, it's very strong and the load to shunt pin is very low. Because I have a lot of case that the resident put in the anterolateral and in the media of the tibia, and then the patient have the neuro condition, and after 2 weeks the broken shunt pin, always broken shunt pin, and have to remove. Yes.
So it work just straight the construct on the
Yes.
film. Okay.
Straight the construct.
Thank you for your recommendation.
Okay, any question from the participant? I have one question for Dr. Songpon. Okay, Dr. Songpon, you mentioned about the one stage and two stage of the bilateral femoral fracture, right? Okay, the paper that you mentioned that one stage mean that put it in the bilateral side, okay, in one time, right? In one setting, right? Okay, and what is the reason of the is it less ARDS in the one stage procedure?
Because they review the surgery in the data is a retrospective review, and they calculate the statistics is the less than in when you do is simultaneously in the same OR.
Okay.
In the setting of the delay, not
Okay.
the early fixations.
Okay. The
After
paper,
DCO.
the paper will explain about the rationale or the scientific.
I'm
Call-
not sure. Sorry.
Okay. Thank you so much. Okay. Any question? Okay. If no. Oh, okay. If no any question, okay, we will end this section in this morning, and the next is a lunch symposium. Okay, we have lunch symposium in here for the wire trees. Okay, and another room for the another company. Okay, thank you so much for joining with us this topic. Thank you so much.